beginning here. So welcome to the 16th Annual Women's Policy Leadership Institute. This is day 6 or 7. We're coming up on the end of the week here. It's been such an awesome and exciting week so far. Thank you so much to everybody who has presented and to all of our presenters coming forward today, including Jackie and Olivia, who are joined with me, and I will introduce them in just a moment. But just a couple of tech notes first. You all are familiar with Montana Women Vote. We have done our little intro at all of these sessions so far. We work statewide to engage low-income women and Indigenous women and families in non-binary, two-spirit, LGBTQ folks, as well as Black, Indigenous, and people of color across Montana for leadership development, policy advocacy, and civic engagement. And today we want to talk about healthcare policy in Montana and federally and what's to come, what's important for everybody to know. So I have two wonderful presenters with me today, as well as some help with answering questions from a healthcare navigator who we're very lucky to have with us to be able to help connect folks to healthcare if you need it. So Olivia Ryuta is the Outreach and Engagement Manager at the Montana Primary Care Association. She leads MPCA's work to identify and impact the social needs patients served at health centers experience. Olivia joined MPCA in 2013 and has worked a lot on outreach, enrollment, and implementation of the Affordable Care Act. Olivia was also the co-director of Montana Women Vote at one point in the past, and we miss her all the time and ask her to come back whenever possible to talk to us. And she helped plan and implement Montana Women Vote's voter registration, get out the vote, issue education, and ballot initiative efforts, as well as lots of other amazing stuff. And Olivia is also just one of the coolest, funnest, kindest people ever, who also happens to be super smart. Jackie Simmons is a policy analyst at the Montana Budget and Policy Center. Her primary areas of research focus on food insecurity, healthcare, and the social safety net. Just some very unimportant things that nobody cares about or needs whatsoever. She conducts research to measure the impact of state and federal policies on the people most impacted by them. And after serving with the Jesuit Volunteer Corps, she moved to Montana and earned her master's degree in medical anthropology with a certificate of public health from the University of Montana. And similarly to Olivia, Jackie is incredibly funny, fun, and smart. So we're just so lucky to have both of these wonderful people with us today. I'll be here as well, sort of in the background, monitoring the chat and keeping an eye on the Q&A box. You can use either the Q&A or the chat. If you have a question, the Q&A is best because I can sort of try to help figure out when the best time to answer the question would be, or we can give you a written answer if that's most appropriate. But please use the chat box to make comments and be active and participate throughout. And we may have some questions for you as we go along. So I'll turn it over to you, Olivia.
Great, and I'll see if my screen sharing works. As we get started. Are you seeing the correct, can you confirm you're seeing the correct one, Ella?
It's not in presenter mode yet, but yes.
Okay. Here we go. Yes.
Correct. Got it.
Oh, the stars are in our favor. I appreciate that. Okay. So I am excited to be back at WPLI. Feels like I've been at WPLI, I think, from the very beginning. And I am so excited to be back again. I'm also really impressed with Montana Women Vote's team this year, and what feels like 2 weeks of WPLI, I feel like you are outdoing yourselves. So we had hoped to have one of our health insurance navigators presenting today, and she is not feeling well. And so I'm gonna present her slides and I'm gonna present my section. I'm going to do my very best, but still welcome questions, and she might be able to join us and answer some of those questions as we go through. So we're going to just do our best and see how it goes. So I am not Cheyenne Rainingbird, but Cheyenne is our incredible health insurance navigator who lives in Browning and serves both the kind of Blackfeet tribe and the areas surrounding her community. So we are going to just jump right in. So I use she, her pronouns. I didn't say that already. So I'm with the Montana Primary Care Association and Cover Montana. And if you've never heard of the Primary Care Association, most of what we do, we're the professional association of all of the community health centers across the state. And so most of the work that we do is really around supporting community health centers and urban Indian health centers in providing kind of comprehensive primary care services. Collectively, our members serve about 125,000 Montanans. There's a nifty little map of where we are. We are in most places except Northeast Montana. And so, but the work that we do around kind of outreach and enrollment, implementation of the Affordable Care Act, kind of work on Medicaid expansion, we have done that since 2013, since the first open enrollment period of the very first open enrollment period. And we started this thing the following year called Cover Montana. It's a website where Montanans can get information and get connected to somebody who can help walk them through that process. It's also, we kind of create a space so that folks who do outreach and enrollment work, so that they can be connected. We provide a lot of training and technical assistance, as there's never a dull moment and things always seem to shift and change. So we've been doing this work for a long time, Cover Montana and outreach and enrollment. And then in August, we were awarded a federal navigator grant, right? So as part of the ACA, there's funding available to make sure that there's folks on the ground who can actually help make sense of what kind of coverage options are available to folks and help them through that process. And so we received a federal navigator grant. And so we're now the navigator grantee in the state as well, which is very exciting. So this is what Cover Montana looks like. We are in the very fun process of redoing our website. So stay tuned, it will look snazzier here shortly. But what we know is that folks are more likely to get covered if they have somebody who can help them. The data from early, from like a handful of years ago, is they say twice as likely. What we know is that health insurance can be complicated, it can be confusing, and people can get frustrated. And so a lot of what we do is really work to connect Montanans who have questions to somebody in their community who can help them enroll. We also started with part of this navigator grant, we started the Cover Montana helpline. That's that 844 number at the top of the screen, because we can't drive to every single community to enroll every single person just because of the sheer size. And so we have a kind of a phone enrollment team who can do phone or virtual. And then we have in-person navigators as well, we're really trying to serve the entire state. So a little background. And Ella, I trust that if questions come in, you will just interrupt me as you go along.
They will, absolutely.
Before we get started, I think it's helpful to remind ourselves how folks get health insurance coverage. And this is from a report from the Healthcare Foundation from 2020, right? Most folks get employer group coverage. So for me, I get that through my partner, he gets it through his employer, but more than 40% of Montanans. So maybe it's through, you either get it through your own employer, a spouse or a partner, or a parent, because one of the big changes with the Affordable Care Act was that younger folks can stay on their parents' insurance until they're 26. If you go to the right on red, we have Medicare, right? So 22% of Montanans, Medicare is public health insurance for folks who are mostly over 65, but also for folks who have disabilities as well, certain disabilities. And then Medicaid, 22%, that green piece. So Medicaid is public health insurance for folks who are low and moderate income. You probably all worked on Medicaid expansion a whole bunch so that it would cover folks at a higher income and also those who don't have minor children in the home. And then you see at the top, we have 10% of Montanans are uninsured, and the little purple slice, the individual marketplace. So that's all of what happens with the health insurance marketplace, sometimes we call it the exchange, but that's Montana's marketplace is located at healthcare.gov. Just a reminder, a little refresher. Before the ACA, about 20% of Montanans were uninsured. That number dropped a whole bunch, both because of the health insurance marketplace piece of it, but also because of the Medicaid expansion piece of it, right? Medicaid expanded, the legislation passed in 2015. In 2016, folks started getting covered. And so that's what we really see, that shift over time. We also see that those numbers ticking up, right? This is the uninsured rate, again, from, I think this is August of 2020. Uninsured rate numbers are a little bit tricky and you kind of get old data. And so we think it's about 10% right now. It's not totally clear, and it's not clear when we're going to have an updated assessment of our uninsured rate, but that's kind of where we're at. So the ACA has had the Affordable Care Act has had a big impact in Montana's uninsured rate, but there is certainly a lot of work there's a lot of work still left to do. So does Medicaid, so Medicaid is included in here. So this is, if somebody's enrolled in Medicaid, they're considered insured. And so a lot of that, right, 2015, our legislation passed, we were still at 15% uninsured. 2016, we dropped down to 7.4. So a big piece of that has to do with Medicaid expansion, because before that, we were in what we called the Medicaid coverage gap. So again, 5% of all Montanans are covered through the health insurance marketplace. So if we look at our enrollment numbers from the most recent open enrollment period, the health insurance marketplace has an open enrollment period. It's the time of year when folks can apply for the first time or can update their application and switch plans. Most private health insurance plans have some kind of an open enrollment period, whether it's, you have an employer plan and every year you get to make changes, right? Every year on our plan, we get to decide if we want like the eyeglasses coverage, and we want to pay more for that or not. And so open enrollment for the marketplace is normally November 1st to December 15th. This year we extended it until January 15th. And so we were coming in to this open enrollment period, right, in the midst of a pandemic, with about 44,000 Montanans covered. One of the big changes that we saw with ARPA was that plans on the marketplace got more affordable. We can talk about that a little bit more later if we want to go into details. And so a lot more folks were able to get a more substantial tax credit, were able to kind of be able to afford a better plan. And so what we saw is by the kind of December 15th deadline, we had 49,000 folks enrolled. A lot of those are folks who just when they applied initially said, auto re-enroll me every year, please just keep re-enrolling me. And so a lot of those folks were auto re-enrolled. And then by the January 15th deadline, we were over 51,000 folks enrolled in the marketplace. So that's a 14.3% increase over last year. And I'm going to talk about Medicaid enrollment on my next section. And Ella, will you please feel free to actively manage my time just to make sure I don't get us off time. So, right, we had open enrollment. So outside of open enrollment, who can enroll and what does that look like? So Medicaid, you can enroll anytime. This is the Medicaid eligibility numbers, the income guidelines for 2021. We're going to get new ones here shortly, or we have them, but they don't go into effect usually until April. So we're still operating under these numbers. Medicaid income is on a monthly basis, but we throw that yearly number in there because I think for some folks, they think about their income yearly. For some folks, they think about it monthly, however your brain works. But you can enroll at Medicaid at any point throughout the year. So you can still do that right now. This is a nifty little, we like to think it's nifty, and then every time I talk about it, I worry that it's so complicated. But the fact of the matter is the way that we determine eligibility is a little bit complicated, right? It's based on the federal poverty level. So this, you can see the family size up to 8, and you can certainly have a family bigger than 8. We usually just go up to 8. And this side, this darker green section, are the annual and monthly income limits for Montana Medicaid and then for Healthy Montana Kids. And so you can kind of see where those eligibility limits lie. And 138%, right, is the Medicaid eligibility limit. We say that a lot, I feel like. But 261 is HMK, which we don't say as much even, but what we know is a lot of folks might have kids enrolled in Healthy Montana Kids, and then the parents might actually be on a marketplace plan. This is to just give you a sense of, so if you find your family size and you kind of go across and either find your monthly or your annual income, to give you a sense of where you would fall on the marketplace in terms of what you might qualify for to help make your plan more affordable. I hope I haven't confused us more with a wonky eligibility chart. So right now you can enroll in Medicaid, and then you can also get what we call a special enrollment period. We like to call them SEPs because that's extra confusing. But essentially, if you have certain life changes, you can get a special enrollment period. So you can enroll in a marketplace plan outside of the regular open enrollment period. And so mostly we see folks who are losing health insurance coverage. We're going to talk about that a lot coming up. Folks who have a permanent move, if you get married, or if you have a baby or adopt a baby and your family size gets bigger. Those are the main reasons we see folks qualifying for a special enrollment period, which allows them usually to kind of get in and purchase a plan in the marketplace. In addition to that, I think the other special enrollment period we see are for folks who are enrolled members of federally recognized tribes. There are some specific provisions for enrolled members. And I will just say that I think it's important to note you must be an enrolled member of a federally recognized tribe, and these provisions and these benefits aren't available to folks who are descendants. I think that that's an important distinction, and depending, and yeah, and so so the way that enrolled members can enroll at any point throughout the year is through a special enrollment period, right? But essentially an enrolled member can get an SEP at any point throughout the year. And so, so folks can still enroll right now if they're an enrolled member and they missed open enrollment. There's also some provisions if more than one, if not everybody in a family is an enrolled member, but one person is, right? There's some ways to fill out that application if the main person applying is an enrolled member. It gives that family some flexibility. So one of the biggest provisions we see are zero cost sharing plans. So enrolled members up to 300% of poverty get what you call a zero cost sharing plan. So they're required to pay the premium, but beyond the premium, there's no co-pays, deductibles, co-insurance, all this out-of-pocket money that you spend when you actually go and see a provider. You still have to pay attention to your network, and you still have to receive benefits that are covered under your plan. But this is an important affordability measure for a lot of folks in Montana. And there's no referral requirement around for folks who are eligible for IHS Tribal Health or an Urban Indian Health Center. That's the ITU. There's no need for a referral when you have a zero cost sharing plan, right? You can go to any provider in your network, receive services that are covered, and you don't have any cost sharing, which is really exciting. So that's for folks who are up to 300% of poverty and are an enrolled member. And then there's this thing called limited cost sharing plans. This is for folks who are above 300% of the federal poverty level. So a limited cost sharing plan it sometimes requires a lot of kind of active management to make sure you're getting all of your benefits and staying on top of it. But there is limited cost sharing. So co-pays, deductibles, co-insurance, but you have to start your care through IHS Tribal Health or an Urban Indian Health Center, and then get a referral out from there. And so it's a way for folks who are above that 300% mark to limit their cost sharing, but it does have more parameters around how someone might access care. And again, I think if someone's on a limited cost sharing plan, the first thing that I'm going to say is you better read all of your documents that you get, really keep track of them to make sure that the benefits that are promised really pan out. And if there's any questions, that kind of folks ask them early. Okay, I keep going. And so a lot of what we are doing with our Navigator project is really we have this in-person team and this phone team thinking about how do we reach, engage, and really address the educational needs of folks who are enrolled tribal members or descendants, folks who are Indigenous, live in tribal communities, and need access to insurance, but also need to understand how to use it. And so we're doing a bunch of outreach, kind of reminding folks that for enrolled members, they can enroll at any time throughout the year, and that for folks who are, depending on your income, right, that there are different tools available to make sure you're limiting those out-of-pocket costs. And so we're doing a lot of this outreach. Cheyenne is very busy doing this outreach in her community. And then I think that we get this question a lot: why do I need to enroll in health insurance coverage if I can access IHS? I think that we hear from folks that we enroll in coverage who are also eligible for IHS a bunch of different reasons, right? I think one of the big things is that it's another tool and another access point for folks to access care kind of when and where they want to. I think that whether that's in a community, I think it's also really important when folks are traveling, right? If you travel outside of a community, if you travel and something happens and you need to go to a hospital, there isn't as much peace of mind that IHS is going to pay for that hospital visit, whether you're traveling kind of from Browning to Billings, or whether you're traveling from, Montana and you're driving to Arizona to find a little sunshine. And so I think that we have this conversation a lot. I think the answer is different for different folks. And then we get the question of, well, what about IHS, right? And in the very beginning, there was a lot of, IHS did a big campaign right when the ACA rolled out, which was all about kind of third-party billing. But what we have seen, right, when folks have insurance coverage and they're eligible and access care at IHS does a lot of third-party billing and is able to use that money ideally to increase the number of services they're able to provide and increase access to folks in their community. And so I think that's an important piece. We also hear from a lot of folks who say, yeah, I think that healthcare should be a treaty right, and I shouldn't have to enroll in the marketplace. And so everybody gets to do what they think is best for them. And really our role as navigators is to answer questions and be available. So if that person changes their mind later, great, we can help enroll them, we can help answer questions. So that when folks, if they're ready, when folks are ready and want to enroll, they can, and that we can support them through that process. Okay, I think that's the end of my first part. I'm going to stop. Any questions, or should I just hand it to Jackie Ella? Whoop, whoop. Stop sharing. Was I on mute that whole time? Just kidding.
No, we would have told you.
Jackie, so I'll pause and then I will come back and do the second part of our presentation after Jackie.
Okay, if we could all collectively cross our fingers, because this did not work the 4 times I tried it before, but I'm going to try and share my screen. Let's see. Okay. Have to do the whole, can everyone see my screen now thing. Somebody stop me if you cannot.
It looks
right.
great.
Okay, good. So I'm going to put a poll up, and if you guys want to answer it, My name is Jackie Simmons. I am a policy analyst at the Montana Budget and Policy Center. It's great to be here talking. I went to WPLI years ago when I first started and just learned a ton. So any answer here is fine. You do not need to know what a Medicaid expansion waiver is to have a very fulfilled life. But today you're going to learn more than you have before. So I don't know how to share the poll results, I guess.
I believe I just did.
Did you?
I can
Okay.
share them verbally if that's helpful.
Sure, I can see them too. So most of us are not very familiar with the Medicaid expansion waiver. Some of us, have heard of it, and 10% of you are very familiar with it. So I'm assuming that is who answered that one. But thank you guys for filling that out. So I'm sorry. So today I'm going to talk about first, what is the Medicaid expansion? What is going on with Montana's, and what we can expect moving forward with our expansion waiver. So a Medicaid expansion waiver is states can put in requests to the federal government to waive certain federal Medicaid requirements. Basically, states can change the rules of the program to fit their own needs. There are limitations. The waiver has to be budget neutral for the federal government. So the state can decide they want to cover an additional service, but then they have to argue about how, covering that service ultimately saves the federal government money down the line. The waiver also has to further the goals of Medicaid. So the state can't say, we're only going to cover half the people. That's all we want to do. A state cannot do that. They have to essentially be doing Medicaid expansion, but if they want to come up with ways that further the goals. Of course, what that means to further the goals of Medicaid changes based on who's in the administration at the time. So Montana has always had a waiver for its Medicaid program. It started with a plan to use a third-party administrator, Blue Cross Blue Shield, to have this public-private partnership for Medicaid. That changed a few years ago, but there were still elements in Montana's original waiver that the Centers for Medicare and Medicaid Services, 2 M's, but we just call it CMS. So there's still elements that CMS had to approve every few years. So in 2019, Montana submitted another waiver application to CMS, and it contained premiums like it had from the start, something called continuous eligibility, which I will explain more in a bit, and it newly included work requirements. Then COVID-19 strikes. We all know what happens next. It just, everything pauses. CMS had bigger fish to fry and basically stuck this waiver in a drawer. It didn't act on approving the waiver and extended the deadline till 2021 before it had to make any decisions. So during this time, the Biden administration takes office, and they just issued this blanket statement for all states saying they would not approve any waivers with work requirements. So this is a big win for people with disabilities, especially those who have not been connected to insurance and might not have medical documentation for their disability, people with elder or child care obligations, people of color who face employment discrimination. This is a big win because work requirements can be just unnecessarily burdensome. Also, plenty of people on Medicaid are already working. Something like 2/3 of businesses in Montana employ workers on Medicaid expansion. So it wouldn't really help anybody work or encourage anybody to work. It would just create a lot of paperwork. That would really be the only type of work happening here. So we've already got one big change to the waiver. Of course, during this time, 2021, we have another change of office, and Governor Gianforte takes office. And his administration amended this pending waiver application to say that they would no longer include continuous eligibility as part of Montana's Medicaid program. So I am going to pause here and explain what continuous eligibility is. So continuous eligibility means that once you enroll in Medicaid, Essentially, you're enrolled for 12 months, even if your income fluctuates above the Medicaid income limits during this time. So this was part of Montana's original Medicaid expansion program, and it was just us in New York State that included this provision for adults. Montana thought it was especially important given the number of seasonal workers in the state, with the agriculture and outdoor tourism being big economic drivers in our state. Not everyone works year round, and so they might need it, but everyone needs health insurance year round, even if their income, they make most of their income just in the summer. So activists had the opportunity to speak out and explain why this was a problem. We had hundreds of people and organizations writing letters, Montana Women Vote, the Primary Care Association, disability rights activists, Western Native Voice, lots of people sharing their stories. If you were one of those people or organizations, feel free to share that in the chat. And a big thank you for if you did speak out against the end of continuous eligibility. Unfortunately, the state did ignore all of these voices, and they went ahead with their request to CMS to remove continuous eligibility. CMS hands were a bit tied here because they can tell a state what's not allowed under federal law, but they can't make a state do something that's not required under federal law. So Montana will no longer have continuous eligibility for adults on Medicaid expansion. This will be a problem for people who see their income fluctuate throughout the year. They will risk turning off and on Medicaid. It will be costly for the state. The state has workforce shortages like everybody else, and it's not really clear if they have enough people to be processing all these additional applications as people turn off and on. And worst of all, it'll probably leave people with gaps in their healthcare coverage. So two big important points I want to make here. Nothing is changing immediately. Olivia will talk more about this, but there won't be any change. Nobody's losing their insurance tomorrow. Nobody will lose their insurance until the end of the public health emergency. And nothing is changing for Healthy Montana Kids. Healthy Montana Kids also has continuous eligibility, and nothing is changing immediately. The other big point is if you are on Medicaid expansion, if you have a loved one on Medicaid expansion, please update your address. The state will have to get in touch with people to tell them about these changes that are happening. And if your address is different than it was 2 years ago, the state might not be able to get in touch with you. So please update your address. Check your address to make sure it's what you think it is. If you work with people on Medicaid, please remind them to update their address. I can say it a few more times if you want. Update your address, ask people to update their address. Okay, so back to the waiver. Montana still has this waiver request just sitting in a drawer in DC, and it is starting to collect lots of Post-it notes and red ink. It has been there from all of 2020, most of 2021. We know now that there won't be work requirements. We know continuous eligibility is going to end, but premiums were still up in the air. So Montana's Medicaid waiver previously included premiums for Medicaid recipients. People were expected to pay about 2% of their income as a premium. People under 100% of the federal poverty line couldn't be kicked off the program if they didn't pay their premiums. But if they were in that 100 to 138% range, they could be. So this is a problem for people who are living on extremely tight budgets, who face an unexpected expense one month. A premium can cause them to lose their health care. So in December, CMS came back to the state and said premiums do not further the goals of Medicaid. So remember, a waiver has to further the goals of Medicaid, and this had been allowed in the past, but now CMS is saying no. 2,800 people lost their coverage in 2017 due to inability to pay premium. So it's a real barrier to access to coverage. CMS gave the state 1 year to wind down its premium program, so it can still charge premiums until the end of 2022. Okay, So to recap, several changes in Montana's Medicaid waiver over the past couple of years, no work requirements, no more continuous eligibility, and no premiums. And now we have until 2022 to deal with all these changes, or to deal with the premium change. So some of these changes are positive. Work requirements can be really difficult for some people with disabilities, people with childcare, elder care obligations. Premiums can be burdensome for people on extremely tight budgets, but the end of continuous eligibility will be a problem. It will mean a lot of red tape, a lot of churn, and uncertainty for some people, especially as it's kind of wrapped up into this public health emergency ending, when it ends. So what happens next? So this virtual application that is just sitting in the virtual door, it's covered in Post-it notes and red ink, and it does not look much like what was submitted 3 years ago. And now the state has this 1-year extension for it. So the state will really need to go back and reassess all these changes. And, it's not really too clear what happens next. So in the meantime, while the state is figuring out what to do with their Medicaid expansion waiver, it is vital for people to keep sharing their stories about Medicaid expansion and how it's helped them or their loved ones. So for example, when CMS asked for comments about the end of continuous eligibility, there were something like 400 comments against the proposal and none supporting it. And CMS gets to come back to the state and write them a letter saying nobody really liked this idea. So it can feel frustrating, that nobody's listening. If you were one of those people who submitted a story and then you find out continuous eligibility is ending anyway, it is frustrating. But your voice is being heard. Your comments are being read. People are listening, and CMS gets to tell the state, we can't make you keep this, but this isn't popular in your state. So it just means that we keep going, keep sharing stories. Montana Women Vote is a great way to share stories if you have them, and we'll just take the next best step. So, thank you.
Jackie, there's a couple questions, if you don't mind, in the chat. I'd love to ask you.
Okay.
Do we know how often they'll be asking people for updated income?
Oh, we don't. And I think, Olivia will know this better. I believe it's when your income changes, you will tell the state.
Yeah, and we'll talk through that. It's within 10 days of many different changes, including income.
The other was a comment, so sorry about that. It was just one question. Thanks, y'all.
So as I engage the technology and try to share some more slides, if folks have questions, so I realize if folks have kind of any other questions that are lingering that they were hoping to get out of today, feel free to put those in the chat and Jackie and I can kind of read them. I can try to include some of them in my slides. I think we're going to have enough time, so I'm going to show you an extra slide about affordability on the marketplace, because that's what keeps me up at night. Okay, so pop any questions into chat, excuse me, and I hope that you're still seeing the correct version. So yeah, so really thinking, so in the first part, really thinking about kind of where are we at with enrollment, where are we at with our uninsured rate, who can still apply right now, and then thinking about looking ahead, right? This is the, what are the really big changes that we are anticipating in 2022? So before we do that, I'm going to just say, we've been saying this a lot. I just want to show it to you. ARPA, the big COVID bill that passed in the spring of 2021, right? We say a lot that marketplace plans are more affordable than ever. And I've been doing this work long enough, like that just seems like something you say sometimes, right? But like never has it been truer. or more true than this moment. And so I just want to point out two pieces, especially as we're thinking about the end of the public health emergency. So this is the expected premium contribution. On the top is the new one, the change because of ARPA. On the bottom is what existed before ARPA. And I want to point out the expected premium contribution has to do with how much you're expected to pay, and then essentially your tax credit makes up the difference to pay the entire premium. So when my expected premium contribution goes down, my tax credit, the amount of tax credit that I receive goes up, because the health insurance company still gets paid the full premium. So, but it feels more affordable for the person. So a big thing is the star on the left. For folks up to 150% of poverty, there is no longer an expected premium contribution. And folks in this, up to this income level, they qualify for tax credits. They also got this thing called cost sharing reductions, which is a wonky way to say for the same price, they can buy into a plan that's better, a higher quality plan that has less out-of-pocket costs when you actually access care. So that's a really big change and an important one. The expected premium contribution went down across the board though, right? So if you look at 200% of poverty post ARPA, someone's expected to pay 2% of their income. Pre-ARPA, 6.52% of their income. So as we've been enrolling folks during the open enrollment period right now, folks who have special enrollments, this really feels different for folks in terms of what they're expected to pay in premiums. And I will just say, so I will also say, because there's a lot of people who have applied to the marketplace in the past and they really wanted insurance, and for whatever reason it wasn't affordable, right? What we know historically before the ACA, people want insurance coverage, but they just need to be able to afford it. And so I just want to point that out, that this is a big change and something to keep in the back of your mind as we're going forward in this conversation. If you have any questions, pop them in there. Okay, so I said we would talk about Medicaid enrollment, and now we get to. So this is from the Montana Medicaid dashboard. If you've never seen it, it's this kind of public dashboard that DPHHS puts out there to really track Medicaid enrollment each month. There's usually a delay, so the most recent data that we have is from December. As we were starting the pandemic, right, 80,466 folks were enrolled in Montana Medicaid expansion, right? And as of December, there were 105 people enrolled in Montana Medicaid expansion. And so you see that, and one of the things that it makes me think of is that, geez, Medicaid is our healthcare safety net, and it did its job as folks were losing jobs, were losing health insurance coverage. When their income fluctuated throughout the pandemic, Medicaid did what it was supposed to do. But in addition to Medicaid doing what it's supposed to do, we've had this thing called the public health emergency. So there's lots of public health emergencies aren't unique to COVID. There's a concurrent public health emergency that we are in currently with because of opiates. They just renewed that one. So we've had multiple public health emergencies other than COVID. But when the Families First Coronavirus Relief Act passed way back in 2020, and one of the things that changed is that states were all facing budget, like it was the beginning of the pandemic, states were facing budget cuts, people were losing jobs and enrolling in Medicaid. One of the things that happened is with this, states got an increased, what we call FMAP, right? Essentially, states and the feds share in the cost of paying for Medicaid, right? It's administered by the state, but that cost is shared between the state and the federal government. But essentially what the feds did is said, we'll pay more. So states, you can pay less of the share of the cost, but you're gonna have to maintain eligibility, kind of not create any barriers, and maintain coverage for folks who are enrolled in Medicaid throughout the duration of the public health emergency. And so what that means is that if I enrolled in May of 2020 because maybe I lost my job, and I enrolled in Medicaid in May of 2020, Montana Medicaid has not reassessed my eligibility since that initial application. And so as we are thinking about, so we're thinking a lot about this public health emergency and what happens when it ends. I'm going to pause and look at the chat. Okay.
Olivia, there has been a request in the chat for if there's any really important statistics or numbers on the slide that you would read them out loud.
Okay. Yes.
In case the text is small, but only
Okay.
if there's things you really want to draw people's attention to. Thank you.
Yes. And I don't know if these statistics matter, but that's helpful. Thank you. Okay. So that's the public health emergency, and that's what happened, right? So Medicaid's doing its job, and also as part of it, right, folks who've enrolled, we haven't been redetermining eligibility because we're in the midst of a public health emergency. So when the public health emergency ends, there's a lot of questions about kind of what happens to all of these folks. What's the timeline? What's the process? And I think the biggest question I get is, when will the PHE end? Well, it was just re-upped, if you will, in January. The Secretary of Health and Human Services can extend it by 90 days. And that extension happened on January 14th, and it will go until April 16th. This is a nifty little thing that I stole from the Georgetown Center for Children and Families. And I will just point out that there's a whole section at the bottom about Build Back Better. Build Back Better is a giant piece of legislation that has passed the House, is stalled in the Senate. There was a lot of stuff in Build Back Better that had to do with access to care, but also some really intentional language about how to unwind the public health emergency. And we're not going to talk about it because it doesn't appear, as far as I can see in my healthcare crystal ball, that is necessarily moving forward. So we're going to look at these top two with the red, right? And so I think the question is, we've extended the public health emergency till April 16th. If we don't extend it beyond April 16th, right? If we just move forward and out of the public health emergency, a couple things are going to happen. The Biden administration told states they give them a 60-day advance notice, right? We're going to assume that they're going to keep that. They're going to keep that promise. We would know by February 15th, the state would be notified. And I assume we would all become aware that the PHE, public health emergency, would end. And so then the state would begin to be able to process redeterminations starting on May 1st. We'll talk a little bit more about that. So that's if the public health emergency doesn't end, if the public health emergency isn't extended. If it is extended, then we kind of just repeat this process every 90 days. And then the next end of the PHE would be July 15th. We would know by May 15th in theory, or the state would know and begin to prepare. And then the state would be able to start doing redeterminations starting on August 1st. What I will say is it's a lot of work that states are kind of communicating with CMS about this process, because we have a lot of folks on Medicaid, on all of our Medicaid programs in Montana, right? But states like New York have a whole lot more folks, states like California. And so it's a lot of work for states to do this. And so there's a lot of kind of, we want to know, and also states actually really want to know, because so that they can really prepare for the end of the public health emergency. I'm gonna pause there. Okay.
There's a couple questions in the Q&A about universal healthcare that I'm saving to the end, just
Great.
FYI.
And I will also say that a lot of our Navigator team is on, and you all are doing a great job. I think if you have questions, I will answer what doesn't get answered by our team at the PCA. Okay, so that's like, when do we think it will end? I think that what's important to note is that, so these are the things we know, that states will have up to 12 months to complete this determination process. They don't have to take 12 months. there's also kind of a financial incentive not to take the full 12 months. So we anticipate that, and we have heard from Director Adam Meyer that Montana will stagger our redeterminations, but what that looks like, we do not know. And when I say stagger redeterminations, I mean that like not every single person on Medicaid is going to be redetermined on May 1st, right? Like that's a lot of work. And so that the redetermination process would be spread out and a certain set of folks would be redetermined each month so they could get through all of those cases, but have the capacity to do that. States have to submit a plan to CMS, right? So, but there's no like yay or nay. I think that plan is an opportunity for us to engage and what is in it? What does it look like? What are the details? Is there an opportunity to provide feedback? I think that plan is an important tool that way. So the department hasn't provided any specifics, right? The end of the PHE, public health emergency, has been talked about in broad strokes, but we don't have like a specific plan with which to share and or to kind of specifically discuss. And we are right, the states are required, the first thing that they're going to do for folks that they can look at electronic data sources and they can see that I make this amount of money and yes, I'm totally eligible, I'm still eligible for Medicaid expansion, that process happens as automatically as possible, right? I think, but even what we know, even in the best of circumstances, right, there are people for whom that will not happen and for whom a much more manual process will be required. The other thing that Director Meyer has said in the Children and Families Interim Committee meeting last month was that determinations would be staggered and also with looking at both eligibility for other programs. So if somebody is on SNAP, right, can we link up their redetermination for Medicaid and SNAP at the same time, right? That seems like a smart move. And then also because of the way that open enrollment falls, our redeterminations for Medicaid are kind of bunched up in the beginning part of the year. And so how do we spread that out as well? So the question we get a lot is like, hey, what's happening? When is it happening? How will I know? And what we're told is that DPHHS will be mailing information to enrollees. And so we're encouraging folks to open their mail, check their notices, and we're going to talk about in a minute how you actually update your address with the department, because I think, as you heard from Jackie, that's going to be an important piece of the work. Do you want me to stop? Are there any questions?
Same as before.
Okay.
Just some broader questions for the end.
Okay, so I think that, so this is a big process. As I was reading up, some state Medicaid directors in other states were like, this is the biggest enrollment event that we have had since the ACA rolled out, and for states that delayed expanding Medicaid since Medicaid expansion. And so it's a really big deal. This is a lot of folks who could potentially, it's a lot of folks who are going to be redetermined. We don't know how many of them are going to be determined over income for Medicaid and possibly lose Medicaid coverage. So people ask me that all the time. I don't know. And I haven't heard any estimates as to how many people are expected to kind of transition. I will say that what we do know is that when someone has a loss of coverage, right, including Medicaid coverage, they are eligible for a special enrollment period on the marketplace potentially. And so what we're thinking about is like, what is this process? How do we support folks who are going to be losing Medicaid in transitioning to a marketplace plan? A special enrollment period, you have 60 days, right, after you lose coverage to enroll. But if you don't want a gap in coverage, right, that person would need to enroll in a marketplace plan before they lost their Medicaid coverage. And so there's a short window of time that we really need to be supporting folks as much as possible to navigate what are sometimes really complex systems. And so that is what we are thinking about and preparing for. a lot going on in the chat. So I'm gonna say, I think that this, in the meantime, right, like we know that the end of the PHE is coming. We don't know when. We're not sure about all of the things that are going to happen from DPHHS. So what can we do? I think that Jackie and I didn't coordinate this point, but encourage everyone to update their contact information. This is how you do that. And I put them in what Olivia thinks are the best order. I think the first one is through apply.mt.gov. And I will say, if this, like, part of what we do as navigators is help people through this process. So look at this information. If it seems too complicated, call us, we'll walk you through it. But doing that through apply.mt.gov, which is our application portal, regardless of where somebody enrolled, right? Even if they enrolled through healthcare.gov for a Medicaid plan, right? We have to tell Medicaid through one of the Medicaid access points about our contact information and if it has changed. You can do that by mail, or you can also do it by fax. If you happen to have a fax machine just sitting around from the 1990s. And so I think what's important on that is to include case numbers and names, right? If you don't have a case number, you can include a social security number. Doesn't feel that secure to me to do that, so you can instead include a date of birth. And so that would be my recommendation, apply.mt, mail or fax. And then you can also visit your local Office of Public Assistance. Those offices were closed during the pandemic, but they are opening/open, depending on your community, sorry. And you can just stop in and say, hey, I have a new cell phone, I've moved, I need to update my information. You can also call the Montana Public Assistance Helpline. We experience some long wait times sometimes in the Office of the Public Assistance Helpline, so you can certainly try. And if that doesn't work, I would recommend one of the other options. Also, you can also call and work with a navigator who can help walk you through these steps. I'm gonna pause. Okay.
And just to
Anything else?
clarify, if people's addresses have not changed, they don't have to take any action.
They don't have to take, right? So this is just proactive, right? They don't have to take any action. A lot of people have just moved, and so for a lot of folks, like, they've moved since the pandemic began. If that isn't the case with you, I wouldn't worry and I wouldn't take any action. It never hurts, right? If you, at apply.mt.gov is the kind of portal where you can go in and access your Medicaid application. I encourage everybody to create an account in that portal if they can. It gives you also access to all of your notices electronically if you don't happen to open your mail or keep your mail. It's a very helpful tool to really kind of be proactive about your account. So I would encourage everybody to do that, even if your contact information hasn't changed. Okay. Lots of stuff in the chat. Okay, so continuous eligibility. Jackie talked about continuous eligibility, right? The reason that we got continuous eligibility is because people's lives are complicated. Their income changes, and if you don't have continuous eligibility, you can really kind of cycle on and off the program, and that's what we call churn. So a couple things. So Medicaid continuous eligibility is going to end at the same time as a public health emergency, right? So there's a lot of big changes happening at the same time for Medicaid enrollees. What Director Meyer has said is that continuous eligibility will revert back to what it was before the waiver, right? And what that means is that enrollees need to inform Medicaid of changes within 10 days. Those include income changes, but it's an extensive list. And I would say you can, if you like reading the policy manual, there's the link right there. And it talks about reporting changes. Currently, under the continuous eligibility, folks are still supposed to be reporting changes within that 10-day period, but they're not being redetermined eligibility except on an annual basis. So I think that there's a lot of information in the policy manual currently about what are the things that would prompt a reporting change that we can think about as we are looking ahead to a post continuous eligibility time with Montana Medicaid. So, but I think that what is tricky is that there's a lot of change that's happening at the same time. And so I think that we are thinking about this work kind of all together, because I think folks are going to need a lot of support as they're making sense of what changes are going to impact them. Do they need support in making sense of any changes? Do they need support and kind of navigating this process at all? Yeah, slides will be available. Okay. Okay, so what can you do to help? So I think the first thing is really referring folks who need help. I think that we have never had as much capacity in terms of navigators and folks who are enrollment assisters to help people through this process as we do now, right? The Navigator grant that we received was the biggest one that Montana's ever received. And so I think the timing couldn't be better that we have a team of kind of in-person and on a team that can help folks over the phone kind of make sense of this process. Really targeted outreach to those who will be impacted. I think with continuous eligibility, one of some of the folks I see I see most impacted are, for example, folks leaving incarceration who might be in a pre-release, who right before that continuous eligibility really allowed somebody to get enrolled and have continuous access to healthcare, to prescription drugs, kind of whatever care they needed as somebody was leaving incarceration. Like, I think that's a really big deal. So thinking about who are those folks who really need to know this, who are the kind of caseworkers and staff who work with populations. And so I think if your wheels are turning, you're like, geez, I work someplace, I'm on the board of someplace, I know someplace. We want people to call us and say, what we really need is you to show up in this place, answer questions, make sense of people's options, right? We would love for you to reach out about that. We're doing our best, right, to try to be in all places. But I think more eyes and the ears on the ground will make our work more effective. I think reminding folks who are losing Medicaid that marketplace plans are more affordable than ever. I really think this is a big piece. We talk to a lot of folks who assume they can't afford a marketplace plan until we do the application. And so really, we recognize that affordability is, like, for many folks, the biggest barrier. And so, so I think it's exciting that the marketplace is more affordable. Certainly for this year, those affordability provisions have not been extended beyond this year currently. And I think if you are going to be impacted, if you know folks who are going to be impacted by the end of the PHE, we really want to share stories. We want to share information. I think it's not clear to us how much we're planning a whole bunch of kind of paid and earned media to get the word out. Because we don't have a comprehensive plan. It's not totally clear what's going to happen with the end of the PHE from the folks at DPHHS and the other end. And so I think that we are trying to do as much proactive planning with the things that we control as possible. These are our in-person enrollment assisters. So Missoula, Helena, Billings, Columbia Falls, Browning, and Bozeman. And then that 844 number is our Cover Montana helpline, who are also navigators who can do Medicaid or marketplace enrollments and or just answer questions. And if you are outside of these 6 places, right, lots of Montanans live outside of these 6 places, if you go to covermt.org and click on Find Local Help, there are other enrollment assisters at hospitals, at community health centers who can also help answer questions and enroll in coverage. Yes, Donna, yes, in Great Falls, Indian Family Health Services has been doing enrollment work since the very beginning. Okay, any questions, Ella, before I do a time check and question check?
Just still saving these for the Q&A at the end.
Okay. Okay, I have one more thing I wanted to talk about. Well, let's go to Q&A, and then we can, if questions come up about, I'll stop. Let me skip forward. Yeah.
So Jackie, you may have thoughts on this as well, and I'm actually going to kind of combine these questions because they're a bit similar, and then let both of you say whatever your thoughts are. Are there any other healthcare policy issues beyond insurance that we should be looking out for? And would universal healthcare make this all simpler?
All right, I've got an answer. This might not be the one that we're looking for. I just have more insurance coverage things that I wanted to talk about. So one other area is Medicaid coverage for pregnant and postpartum women. So right now, like Olivia said, nobody's getting kicked off of Medicaid. So pregnant women who are on Medicaid because they were pregnant and had a baby are still on it, which is great. There's a couple things that Montana could do, though, to make this even more accessible. So right now, women qualify for Medicaid coverage if they're pregnant and have incomes at 162% of the federal poverty level. These numbers are ridiculous. I know, 162%, 138%. But so that's a lot lower than the rest of the country. The rest of the country is closer to 200% of the poverty level. Again, these are people starting families. They're like 162% of the poverty level is not a high income, especially when you're looking at caring for a child. So ARPA, one of those big bills that Congress passed at the beginning of the pandemic, has an option in it for the state to continue funding Medicaid for pregnant women for up to a year after the birth or the end of the pregnancy. And right now it's 2 months. So I have had 3 kids, and I can tell you that the healthcare that you require does not end 2 months after you have a baby. And keeping women connected to coverage is essential, especially in this time period, for not only the parents, but for the children as well. When parents have healthcare coverage, their children are more likely to. When parents are healthier, their children are more likely to be healthy. So this is a big opportunity for Montana to decrease some of those impacts of people losing insurance because of the end of continuous eligibility in the public health emergency. It's a great opportunity to provide stability for families. So that's not quite a non-insurance question, it's just another insurance question or opportunity for you. As far as universal healthcare goes, I would like to say that I work in healthcare policy, and I also called the navigators to ask a question, and Olivia helped me figure it out. Not because it was so complicated to navigate the website or anything. I just had a specific question I couldn't find an answer to. And so that's what I think a lot about, is that just the amount of time. I mean, even if you put the money aside, the money is a big issue. How much we spend on healthcare, how much we spend on healthcare insurance, how much we spend after we have healthcare insurance. That's what we talk a lot about. But I always think about just the time that we spend arguing about who should get healthcare, and the time we spend trying to figure out what our healthcare covers and where we can go to the doctor, and if we should go to the doctor and how much it's worth. That is just, for me, a huge element. I think if we had universal health care, we would all just get so much time back. We'd get a lot of money back too. I mean, it would be a more beneficial for our economy, but it would free up a lot of time. But so I would like to put in a personal plug. If you have health insurance comfort questions, they really can help you answer it. So.
Anything to add, Olivia?
So, right, the ACA, it's all health. I mean, it's public health insurance, it's private health insurance, right? I think that it's a health insurance system which is inherently confusing and challenging and requires a lot of time and energy often to kind of track that process, make sure that what is supposed to happen is happening. And so I think that, I think that a lot of what we're doing is trying to, what we say, improve health insurance literacy. Essentially, like, research says that everybody, if you had health insurance your entire life, you don't know how to use it that well. And so so a lot of what we're doing is spending our time teaching folks how to use health insurance. I think that there's a lot of other ways to deliver care, and a lot of other countries deliver care in other ways that don't rely on the same kind of insurance structure, and it costs less and there are better health outcomes. And so I think that is always helpful because there's models that exist, right? It's not like a mysterious structure. But at this moment, we exist in this health insurance structure where we're kind of incrementally trying to move affordability, improve access, and it is inherently complicated and confusing. Sorry. Wah,
So
wah.
we should all move to a different country. Just kidding. That is the last question that we have so far. So if folks have further questions, go ahead and use the chat or the Q&A. And Olivia, if you wanted to show us your secret additional slide that we
So I was just
have.
gonna say, I think one other thing that's happening that we are just beginning to really kind of talk about is, and I don't have to show the slide, I can just talk, can I though? That's the question. Is the No Surprises Act, which is a piece of federal legislation that it's really a consumer protection piece of legislation for folks on private insurance plans. I should look at my slides and then I'd know exactly. But it's for employer coverage, marketplace, or individual health insurance plans. But it's really getting at surprise medical billing. I think that surprise medical billing is, I think there's two kind of classic examples. I go to my provider, I need blood work. My provider is a network, great. I love them. The lab processing my blood work is not in my network, and they are going to balance bill me. They're going to charge a higher rate than what my insurance company has negotiated, and so that's called balance billing. I think that's one way that we see it. I think another way that we see it is Olivia has a heart attack, or I plan to have heart surgery. I go to St. Pat's, great. My cardiologist is a network, St. Pat's is a network. But lo and behold, in the midst of my heart surgery, an anesthesiologist or somebody on that team is out of network. I thought I did all the right things. Lo and behold, I did not do all the right things. And so really trying to protect folks in those instances. It just began. It's really being implemented starting on January 1st of 2022. And so we're really starting to dig in what this means for folks, and what do people need to know? How do they access? How do they really kind of track this stuff? I think the good news, bad news is that the way that it's a lot of the kind of time is on us to really track our own health insurance coverage and to track our billing, and to then be able to say, hey, I think this is wrong, but I think that it requires a lot of attention by those who have insurance and are accessing care to make sure that they are not, that they're being billed appropriately. So we're going to be doing some more work around that if folks are interested. I think it's promising. I think it's complicated. I do think it gives us a few more tools to make insurance work better for folks.
And it is complicated. And there's a lot of sort of questions and comments in the chat about talking to people in Congress and talking to lawmakers, and how difficult it can be to have a grasp of our healthcare system and all of these policy issues. And I think that Janice, your comment in the chat about this, it really reinforces what both Jackie and Olivia have mentioned a couple of times about the power of personal stories. Because these wonky policy issues are really, really difficult to wrap your head around. But when you can walk in to a lawmaker and say, I found a lump and I just wanted to get a mammogram, and because I found it myself at home and wasn't referred, now my insurance is billing me XYZ. And you can share stories like that happen to people every single day. And that is what helps people to understand the issues with the policy issues with our system. There also was a question in the chat around a preference for Montana Primary Care Association and Cover Montana over DPHHS in terms of being able to reach people. So it seems like that question was answered in the chat, but I would definitely encourage you to reach out to Cover Montana if you need to update your address, if you're having issues and you need to talk to someone on the phone and you can't get DPHHS on the phone. You might even try Cover Montana before DPHHS, because you probably will wait on hold for quite a while.
I like to say that our goal is to, like when we're enrolling folks, when we're helping people, that they never have to call the public assistance helpline or kind of head over to the OPA. And so, so I would just, we have an online chat too, if you like online chatting. But yeah, so if we can be helpful, reach out to us. We have time and capacity, and this is what we do. And so it's not a burden to answer a basic, I like to say it can be a small question. It can be a giant question. It can be walk me through that entire process. I don't want to do a Zoom share. I want you to read me the plan details of all of the plans. Great, right? Whatever folks need, our goal is to kind of provide that. So I would say reach out first, and we can, the other advantage, right, is that if you call one of these smart navigators who are chatting in the chat and you're like, sweet, right, Tierney enrolled me in Montana Medicaid, in 3 months, when you go to your provider and something goes haywire, you can call Tierney back up and be like, I don't understand. Like, I thought I was doing the right thing. And then a lot of what we do is really kind of work with folks to make sense of what happened, what should be happening. Do they need to appeal? What does that look like? So so I would say when in doubt, give us a call. We would love to help.
What can be done
Can I say
about
one more thing, Ella? So I think that one of the slides that didn't make it in the last minute, I don't know where it went. I thought it was there. So I think that there's a lot of work that we can do to know our own communities, know our own families, and like be proactive, be coordinated. And then we should be talking to our elected officials, right? There are interim committees meeting between legislative sessions who have the opportunity to ask questions of DPHHS, who have the opportunity to kind of create space to create space and talk about these issues. And so what I would say is call your local elected officials, your House member, your Senate member. What do they know? You know, can they help provide information? Can they help advocate? Do they know how this is going to be approached in their community? I think that there's a lot of power in that. And so definitely engage. I know that there's some elected officials who joined us today. Thank you. And I think asking questions is really important right now, and because we've been getting some information, but you know, it's not a comprehensive plan that we're able to provide feedback on. And I think that that would be helpful. And then we could all do more as we're helping to prepare for what's going to inevitably kind of be a really big shift and a lot of work. So call your elected officials.
Well, there's some awesome conversation continuing in the chat, but I thought I would close today by just asking the two of you if you have any final thoughts that you wanted to share with everybody.
Yeah, I think so we're, almost on year 2, finishing up year 2 of a pandemic, and it has been hard. And also this terrible social experiment of like what happens when we help people and give them sick leave? What happens when we don't, give people sick leave? What happens when we give people health insurance? And what happens when we don't give people health? Like if we take it away and coronavirus is still raging. I think like right now we're all in survival mode to some degree. And as we come out, we're gonna, in years from now, we're gonna learn a lot from this time. And it's not always going to be like what, it's not, that doesn't really make you feel better. Like, oh, this is, at least it's a learning experience. But I think that there are a lot of great things that have come out of some of this legislation, that's been passed over the last few years. And my hope is that we have really learned to value health insurance or health access to healthcare as a right, whether that's through insurance or universal healthcare coverage. And I think that, this pandemic hopefully has been a lesson in like, why we need help, like why healthcare matters and why it matters for communities who are hit harder by, the tribal communities had such a harder time of the pandemic, and how important access to healthcare is for our families and communities. It's still there, it's still a long road ahead of us of, minimizing the damage of some of these changes, like the end of the continuous eligibility. But I think that there are a lot of good things, like the marketplace is a lot more affordable now, and hopefully we can use that progress and build some momentum with it.
And I'll just say that we have done amazing things in Montana in the past, right? Like you think about the states, like I remember when like Medicaid expansion passed and we started enrolling folks, and that feeling of being able to say to somebody who needed care, like who didn't have care before, we are good at advocating. We are good at kind of putting faces and names to complex health issues. And so this makes me kind of thankful that we know how to do this. I think that we're all very tired. And I think that it's an opportunity for us to kind of flex our muscles. Like we have muscle memory and how to do this organizing work and this advocacy work. And so I think we, if you're feeling like we're coming out of the pandemic, if you're feeling like we're going back into it, however you're feeling, I feel like it's a way to focus on, like shift your energy and think about what we need to do in the next 6 months. But I really kind of, I have seen what Montana Women Vote and many of the folks on here have been able to do. And I think we can do a lot if we really organize, tell stories, and engage our elected officials and ask them questions and ask for information. So I am thankful for all of you, right? This is actually helpful because sometimes I think I just lay in bed at night and think about the wonkiness of the PHE and SEP deadlines, right? Like we're all in this, and there's a lot of power in this virtual room. And I appreciate all of you, and I think that we're all going to need to engage.
Well, thank you both so much. Montana Women Vote is so excited to do more work, moving in a little bit more to the enrollment space and sort of connecting these issues of services and access to our civic life, because they're not separate, as we all know. And sharing your story is a huge part of being able to allow for other people to access healthcare as well. And voting and all of these sorts of things, it's all interrelated. And I think that the more that we can communicate that with our communities, the better. And that really is some of the work ahead for us at Montana Women Vote. So please get in touch with us if you're interested in that, especially if you know people in your community who don't have health insurance, have had times when they didn't have it and are interested in advocating based on their own stories. We would love to help people get covered. We would also love to help people advocate for greater healthcare for all of us. So thanks again to our speakers. Thanks so much to everybody who joined us. Please fill out our evaluation. One of the staff members is going to pop that link into the chat. If you complete our evaluation, every single time you complete it, you will be entered to a raffle to win What We Don't Talk About When We Talk About Fat by our keynote speaker, Aubrey Gordon. Absolutely amazing keynote the other night, which is up on YouTube. It's an awesome book. There's also a Visa gift card in there, but you really want the book, I'm just saying. So